Bon, alors, bonsoir, mesdames et
Well,
messieurs.
welcome everyone, ladies and gentlemen. Welcome to Procure en Parle, because information is the best medicine. It is our pleasure to welcome you to our sixth webinar of this fall. Our topic for tonight is the role of hormone therapy and managing side effects with Dr. Carole Lambert, a radiation oncologist at the University of Montreal Medical Center. She will give us a presentation and then we'll have some time for questions and answers. Speaking of questions, thanks for those that you have already sent us at info@procure.ca. And you can also put them in the question and answer for this webinar. Before we get going, we'd love to thank all of our donors and also the official presenter sponsor of this webinar, Industrielle Alliance, and our partners, Astellas, Bayer, and the Association of Urologists of Quebec and Canada. Thank you, Dr. Lambert, for having agreed to speak with us, and I'll pass the microphone to you, and you can go ahead and share your screen.
Ça me fait vraiment plaisir.
Okay, it's a real pleasure to be here with you tonight. I hope that you can hear me okay. So we're going to start with just a brief overview here, just some general information about prostate cancer, but we also know that there are a lot of subtleties. So what I'm going to say here is general information, but the main goal here is to talk about hormone therapy and especially the overall effects of that and what you can do to maybe diminish some of the side effects of that. So let's talk a little bit about Gleason score and staging and what that means. So here's how your Gleason score is calculated. It's the grade of the tumor and how aggressive we presume it to be. But let's look at what that's made up of. When we take biopsies or you have an operation and you have your prostate removed, then the pathologist is going to analyze cells under the microscope and is going to grade that tumor, and it's going to see if it's aggressive or not. And each time they do that, they're going to do the grades from two sections of each specimen that they analyze. And the score is the sum of those two scores. And if you have 1 out of 5, 2 out of 5, that's not so serious. But when we look at low-grade tumor, it's a score of 6 or higher. And then as we go up there, we have average aggressivity, but the very high aggressive tumors are sort of 9 and 10. And then when we look at the stage and scope, we talk about staging, the initial stage of the tumor, and maybe it could be stage 1. And when you have a rectal exam, it can't be felt, but we can see that you have an elevated PSA, a small tumor that could be in one lobe or maybe a little higher. Maybe it affects more than half of the prostate and it can be felt. Stage 3, it's going to go outside the prostate capsule, or it can even be in the seminal vesicles that are attached to the prostate. Then we move up to stage 4. That's when it has metastasized to the surrounding tissues, the bladder, the rectum. And then finally, we're going to have to look whether it has gone into the nerve tissues in the bladder or in other organs. That could be a stage 4. Then if the tumor is sort of average or higher aggressive, then we're going to do other tests there. We might do a bone scan, a pelvis scan, or even an MRI. And I'd say we're doing more and more MRIs because those can give us a better image of the scope of that tumor that's inside the prostate and whether it has already breached the prostate capsule. And that can help us sometimes to give a higher dose of radiation to certain areas of the prostate. So just in the very big picture, because everyone's situation is unique and you've really got to talk to your doctor, but let's talk about treatment options. So if you have an intermediate risk tumor, you might have a radical prostatectomy, you might have external radiation therapy, where you receive radiation that is aimed from outside your body onto the prostate, and that may or may not be combined with short-term hormone therapy. And when we say short-term, that's often 4 to 6 months. Or you might have external radiation therapy with also what we call Curie therapy or brachytherapy, which is kind of a very focused form of radiation therapy. And that's where we insert a catheter to really put the radiation therapy right into the prostate. And in general, we're also going to combine that with short-term hormone therapy. And here is where we're talking about really trying to cure the tumor at that level. So then higher risk, you might have radical surgery, but then you can see here that the hormone therapy is going to last longer, 18 to 24 or even 36 months. And that really depends on all the factors that we'll look at. You'll talk to your doctor, your oncologist, urologist, radiation oncologist about what we think would be ideal given your whole situation. Now, what if the cancer is already metastatic, and that means that it has gone beyond the prostate and it's in your nerve tissue, sometimes in your bones? And so then you might have so-called standard hormone therapy. That's what we're going to talk about in depth today. And it's probably going to be long-term hormone therapy, maybe for the rest of your life. And we might do what we call new generation or next generation hormone therapy. And you can see that there have been a lot of changes in the last few years that have increased the effectiveness of that type of hormone therapy. Now, let's look at the type of hormone therapy. There are a lot of different ones, but here is really the goal is to decrease or almost completely eliminate the production of testosterone, because testosterone, it comes and sort of stimulates or even feeds the cancer cells for prostate cancer. So let's look at the types of hormone therapy. So when you get a prostate cancer diagnosis, you might have hormone therapy, but that by itself, it can't cure prostate cancer. But it's going to be an effective treatment in reducing the size of your tumor before you have another kind of treatment. Or it might increase the effectiveness of another treatment like radiation therapy. So it's sort of a synergy when we give you both at the same time because they act in different ways, so it's more effective. Or it might be an sort of adjuvant therapy because you might have local treatment to the cancer, but then the hormone therapy affects your whole body. And it might be the best treatment when we look at the start and see that your prostate cancer might not be completely curable, but hormone therapy might help. So there are a lot of different types of hormone therapy, and that could be injections, an implant. Sometimes, usually it's an injection, but sometimes we might give you a subcutaneous or intramuscular implant. You might take oral medications, pills. So you take those to block the effects of testosterone, and rarely people might want surgery. And we call it surgical castration. And that's where we actually remove the patient's testicles, and that is like having injections for the rest of your life, because your testosterone comes from your testicles. And so if we remove those, then you have no more testosterone produced in your body. So let's look at the sort of frontline hormone therapy, or the most standard. And probably a lot of you on this webinar have had a combination of some of these medications. And we call those LHRH agonists. And so these have been around for decades. And so you can see the main categories there: leuprolide, goserelin, triptorelin. And these have been out on the market for a long time, these LHRH antagonists. And they have sort of slightly different delivery mechanisms, but they're all really testosterone blockers. And those are like Casodex is the most common anti-androgen there. But we might give them in combination. And that's just done as a function of, we look at all of the characteristics of your illness, and you might take those LHRH agonists, but from one class to another, from one category to another, there are small differences that can be significant depending on your clinical presentation. So standard hormone therapy, let's look at how that is given. And in general, it is injections. And they might be every month, every 3, 4, or 6 months. And that depends on how long in total we plan on giving you hormone therapy. I'd say most time, the first category that we give you, those LHRH drugs, sometimes we give them with a testosterone blocker for 30 days, the first 30 days. And for the second category, we don't have to give testosterone blockers because those are combined medications that block testosterone production. And sometimes we give people continuous hormone therapy if we think that they're going to be on it for the rest of their lives. But sometimes we have situations where we give what we call intermittent hormone therapy, and we're going to do 7, 8, 10 months of hormones. And after that, we're going to just observe for a while. And we're going to see what the biochemical response to that is. Is your PSA going down? We're going to look at various test results and see if your disease is under control. And if your PSA goes up, then we're going to do another sort of many months of hormone therapy. And the goal is to decrease the side effects in general of the hormone therapy while still giving you the benefits. What should you know about the effectiveness of hormone therapy? In most patients, they're going to see benefits for several years that it can control the cancer. When your PSA goes down and stays stable, then that tells us that the hormone therapy is working. But sometimes over time, our hormone therapy patients, if they're on these treatments for a long time because they have recurring or metastatic tumors, then you can develop what we call resistance to hormone therapy. So even if the testosterone level stays low, the PSA level can start progressing. And so when that happens, sometimes we'll add another type of treatment to control that disease. And then sometimes when you see your PSA really shooting up over a short period of time, that might mean that your cancer has metastasized. even if it was localized before. And what we'll do then is probably add one of those new generation hormone therapies, and those are usually pills. Now, those new generation hormone therapies, we can see lists of the molecules that they might use, and there has been so much progress. I would call it really spectacular in prostate cancer treatments in the last 10, 15 years. So even sometimes doctors, we get lost in all this new information. So it can be hard for patients to absorb all this too, but you can see here all of the molecules that we have access to now. And those are still effective even when we see an increase in the PSA despite frontline hormone therapy. And we use them in all kinds of clinical situations. And if you think that this might be helpful for you, you could talk to your doctor about it. So the idea of these new generation drugs is that it sort of works around the base mechanism of that standard hormone therapy. So standard hormone therapy seeks to decrease the testosterone in your blood, but sometimes you develop a resistance to that. But sometimes these new generation drugs can work through a different mechanism and really go inside the cells and different delivery mechanisms. So those come and they can work around those cells that have become resistant. So hormone therapy is really kind of a miracle treatment. It's very effective. It's a lot easier for patients to tolerate than, let's say, chemotherapy, for example, that it really affects your whole body. So for the majority of other types of cancers are going to have chemotherapy, which affects really your whole body. And so the side effect profile for hormone therapy is really going to be much more tolerable than chemotherapy, but it can still affect your quality of life. And the side effects really depend on the type of hormone therapy that you have, the types of medications that you're taking, and the other treatments that you're having at the same time. But of course, your overall state of health really affects that. Here you can see a list of the most sort of obvious or the most common side effects. And the first one that most people mention is the loss of libido, the loss of your sex drive. And often, we say like libido isn't just, how much you want to have sex, but it's motivation or your sort of drive in life. And a lot of people say, you just don't feel like, taking walks outside, exercising. I just feel less motivated. And that really is testosterone at work, that drive. So people feel sort of more tired. And when we decrease your testosterone, lots of patients say it's sort of like menopause. So, women who are around 50 years old, our estrogen drops precipitously, and some people get hot flashes, and men can experience that too when your testosterone level falls. And sometimes it can be mild, but I've had patients that it was really hard to tolerate those hot flashes. Some people gain weight, and partially because you don't feel like exercising or other reasons. And you can also lose muscle mass. And all of that is, just you don't really feel like doing as much. it can weaken your bones and make you at higher risk of osteoporosis or having, fragile bones. It's important to address that because it's not a good thing in the long term if you're at high risk for that. It can cause mood shifts, same as menopausal women. And you can have, some women have no big deal, and some women have a lot of mood issues. And it's important, if you feel that, to talk about it. Once again, it can be treated. And finally, we have a higher risk of what we call metabolic changes. And by that, I mean your blood sugar may be a little bit higher. Like if you were pre-diabetic before hormone therapy, it can kind of push you over the edge there into the diabetic range. And you might have to take medication for that. It can increase your blood pressure, and maybe your blood pressure medication, if you take it, might have to be adjusted. And it can also put your cholesterol out of whack a little bit. And all of those changes, you might be at higher risk of things like heart attacks or cardiac events and bone breaks, because your bones can be more fragile. And not everybody experiences all of those side effects, but we look at your baseline risk goes up for all of those. So it's important of being aware of those and what we can do to decrease those risks as much as possible. Now, we were talking a little bit about metabolic effects of hormone therapy. Weight gain, definitely, especially in your abdomen area. And your muscle mass may decrease, your blood sugar and your cholesterol and blood pressure may increase. So the real question is, what can we do to ward off these side effects? And the main thing is to talk to your family doctor, your general practitioner about this, so that they know that they can monitor you for all of these potential side effects, because you might be taking this drug, cholesterol drug, for years, and your cholesterol's under control, and then you start hormone therapy and it's not controlled anymore. Now, so at its baseline, hormone therapy can affect all of these factors. And if you don't feel motivated, and before you were, let's say you were walking an hour a day and now you don't really feel up to it. So that can have an effect on all kinds of things: blood pressure, cholesterol. If you feel like, I don't feel motivated to even eat vegetables, and I'm just going to order a pizza, because you have, less motivation, you feel kind of down, sad, and it's like a snowball effect. So it's important to be aware that hormone therapy can cause these types of changes. And if you feel more anxious, under more stress, if you drink or smoke, sometimes people do that more, and that can exacerbate the effects of hormone therapy. Now let's talk about your role as a patient. Where do you have power or control? Because a lot of times when you get diagnosed with cancer, you feel totally out of control, and you feel like it's just the doctors who are deciding what's going to happen to me. But that's not true. You definitely have a role. And it's really important to be up to date on what the options are and to talk to your specialists about it. And you can talk about what are the different types of hormone therapies that are out there, how long are they going to last, learn about the side effects. And you also want to inform your doctor, like tell your family doctor that you're having hormone therapy, or tell your specialist about your pre-existing health conditions if you have any. And then to really ask a lot of questions about hormone therapy, how hormone therapy might affect any health problems that you already have, and ask whether intermittent hormone therapy might work for you. Now, with your general practitioner, your family doctor, it's really important to tell them that you are going to be starting hormone therapy, and then to talk to her or him about what you can do to manage the other risk factors that you have. And it's important to regularly check your cholesterol, your blood sugar, and your blood pressure and things like that. And at least once a year, if not every 6 months, that having somebody who is monitoring that and who can adjust any medications you might be taking to optimize your overall health. Because hormone therapy is for prostate cancer, but we have to look at your overall health. And we really want to make sure that we're winning on all fronts, the cancer and your overall health. So definitely the best thing to do, and if we have what we call a miracle cure here to manage or decrease the majority of the side effects of hormone therapy, and your doctor might have other ideas, but I would say up your level of physical activity and exercise. That really is the key factor that really improves all of the other side effects. The only problem is that with hormone therapy, we're going to take away your motivation and then tell you that you have to do more. But it requires a lot of discipline, a lot of self-control, telling the people around you that they should encourage you, and they're in there with you and they can encourage you. So what is the role of physical activity here? Why is it so great for these side effects? So physical activity is good for decreasing cardiovascular risk in general. So it's going to improve all of your numbers there, everything that is related to metabolism, and decrease your risk of diabetes, your blood pressure, and it's great for weight management also, and also for your bone density and your muscle mass and things like that. And it really helps absolutely everything. So it can increase your muscle mass. And when I have the time, I like to do some a gym workout, and it's because it's good for your bones. And afterwards, I am always glad that I did it. It's good for my mental state. I've been doing that really my whole adult life, and it's good for my muscles as well. It helps me sleep better. So I think you might sleep better if you do this type of exercise as well. It also helps our cognitive function. You probably find that you can concentrate better. It decreases your risk of osteoporosis. It's a good stress management tool. It's really one of the best medications that we have out there for everything that has to do with emotional problems or our mental state. And that can be in life in general or related to having cancer as well. And even if it's counterintuitive that when you exercise, you think you sleep better, but yes, you do, because you actually are going to feel less fatigued. And the other thing that you can do is eat as healthy as possible. So we tell people often to eat real food, food that is not processed. So fruits, vegetables, greens, spices. And if you have someone who can help you with cooking, or really if you can find a way to eat a healthy diet, that's really going to help improve your overall state of health. And if you don't know where to start, we've got resources for you because we can give you a referral to a nutritionist who can talk to you about what you're doing right now and how we can improve your diet. There's a lot of information out there that is available for you on Procure's website. We have info sheets that are there, and it's kind of a summary of what we have talked about, what you can do to improve your overall state of health. For example, cardiovascular health is particularly important when you're on hormone therapy. There's one for patients and there's one there for doctors. And you can download them, you can print them, you can share the content with people who you're close to, take it to your family doctor. And here you can look at set a goal maybe for the next month. And then the important thing is to not try to make these massive changes all at once. And if you have a lot of things that you'd like to improve in your lifestyle, the important thing is to just take some small steps, because that's how there's a bigger chance that you'll stick with it and reach your goals. So you might have a lot of noble goals here that you can try to reach. So either maintain your weight, because hormone therapy can present a challenge. So you could at least seek to maintain your current weight, if not lose a little bit of weight. And that may help you feel better, and it will definitely decrease your risk of developing other health problems. So you could talk about your doctor and find out what would be your ideal weight. And for exercise, we can see the current recommendation here, which is 150 minutes a week. So you could divide that up however you want throughout the week. And so that is, we're talking about something sustained. So walking fast, riding a bike, something that raises your heart rate at least a little bit. Sometimes it's more motivating if you go to the gym and you work with a trainer who's going to give you a specific workout, and they're going to look at how you're doing now and how you could take the first step to improve. They might give you some goals that they sort of cheer you on. So that's something to think about in terms of motivation. And because hormone therapy is definitely going to take away some of that motivation. And sometimes you might pair up with somebody a friend or family member, and go exercise together. Now, talking about food, you really want to focus on fruits, vegetables, whole grains, and you may need to take calcium and vitamin D supplements also. It doesn't have to be in a pill. Sometimes if you have a diet that's very high in those things, you might not need it. But for most people, there aren't that many people who are going to eat the recommended amounts of those nutrients. And so sometimes when I ask my patients about their diets, it's kind of unusual that people have a diet that's that high in vitamin D. And so sometimes we'll talk about foods that have those in them, but you can also take supplements. And then ideally, you want to limit the amount of alcohol you're drinking if you're having some wine to sort of boost your mood at the end of the day. We're not going to tell you not to do that, but excessive alcohol consumption is not a good idea either, because that can increase your risk of all types of things, and it might have even worse side effects from hormone therapy. When we have patients who smoke, we really try to convince them to quit smoking, because that, in addition to the hormone therapy, adds even more risk factors for heart problems and just your overall health. So we encourage people to quit smoking. There's lots of really useful resources there. And sometimes people tell themselves, oh, it's not going to work. But there are professionals and specialists, the people who work on the toll-free quit line. They are really amazing and have lots of ideas for you. And we encourage people to think about stress management. And sometimes you could participate in a stress management workshop, but also do things in life that make you happy, and tell yourself, like, what would help me out just for today to feel a little bit better, and think about yourself. Talking about blood pressure, you can see the target numbers there to be below 140/90. And if you're diabetic, you might want to aim for a lower number, 130/80. And then you can see for blood sugar and cholesterol, the recommendations there. And so you might want to talk to your family doctor about those. If you are already taking heart medication or diabetes medication, you want to really stick with that. And so maybe talk to your doctor about that and make sure that it's being optimized, but definitely keep taking those, because those can be really helpful. If you have annoying side effects from those medications, and sometimes that happens, but they may be able to switch out that medication for another one, and it might help you tolerate those better. So just to wrap up here, even if there are a lot of things that you don't have control over, there are a lot of things that you can do. It's really important to keep that relationship between what's happening with your specialist, what's going on with your family doctor, and so that both of them know about your overall state of health. And if you have side effects and you're not telling anyone about them, then you're not going to get any help. You're not going to get the help that you deserve. The important thing is to talk about them. And there are lots of things that we can do to help you manage those side effects. And years ago, we used to talk about prostate cancer as really a deadly cancer. And now we think of prostate cancer, in the vast majority of cases, it's more like a chronic disease. That's good news in the sense that you can learn to live with it, kind of like diabetes. But that really means that you might need different types of treatments to maintain your quality of life. It's really important to fully understand your disease, the available treatments, so that we can really optimize your quality of life. Because for some people, this goes on for decades. Thank you so much. Thanks for your participation. And I am available to answer your questions. Thank you so much, Dr. Lambert, for that presentation. So now we're moving on to the questions and answers. We've received a lot of questions. How long does it generally take until we know if hormone therapy is working? So in general, once we start the hormone therapy, we're going to do blood work. Maybe within 3 months of starting the treatment, and usually it's pretty quickly that even at the first blood work, we're going to see a significant drop in the testosterone level. And for almost all of our patients, we're probably going to look at their PSA levels, and those are going to stabilize too. So it's fast. Thanks. So injections that you get every month, every 3 months, is that better than 6 months, or does that make a difference in terms of side effects? Typically, all of the drug companies that market injections that are different durations, they have different effectiveness profiles for how long it works. And sometimes when we see people who are in very long-term hormone therapy, we're going to vary those because we want to try to do the least injections possible because they're going to have them for years. But otherwise, there really is no link between effectiveness. It's really more a practical question, how often you have to get the shots. Are there people who react very poorly to hormone therapy for side effects? And if yes, can they change you to another type of hormone therapy? Or what happens? How does that work if someone has really intense side effects? Yeah, it's a great question. So most types of hormone therapy have about the same side effects. Sometimes when we change from one category, or such as an antagonist to an agonist, then you can change, the side effects can change. So sure, we could try another form of hormone therapy, and sometimes that really helps. But sometimes it's just the fact of having lower testosterone causes people to have those side effects. I'd say it's a minority of patients who come to me and tell me, I want to stop this because I have so many side effects. It's a tiny minority because it's related to low testosterone levels. And so there we have to really look at what should we do if they're having these horrible hot flashes? Can we give them a different medication for that? Or people who feel actually clinically depressed, maybe we treat the depression. And yes, there are things we can do. Thanks. Here's a question that a few people asked, or maybe to talk about PSA, was people who said, I had a hormone therapy, and when people stop it because of your testosterone levels, do I have to restart the hormone therapy? Yes, it's in in general, it depends. So when we stop hormone therapy, that's because we hope even if the testosterone level starts going up, that the PSA level will stay low, either permanently if our goal is curing the cancer, or at least as long as possible if the goal is to control the cancer for as long as possible. So when we do intermittent hormone therapy, but the patient has a non-curable type of prostate cancer and testosterone starts going up, we hope that their quality of life is going to be better, but that the APS is going to lag behind. It's not going to rise as fast, so that person has a good quality of life, but the cancer is still kind of dormant, if you want to put it that way, then it has overall benefits. So it's really the PSA going up that's what sort of really tells us that we have to start a new type of therapy if we're talking about intermittent hormone therapy. Kind of hard because it's specific to the patient, but in general. So no, I think that was a great answer. It's trying to balance out between, is the testosterone going up, but is the PSA low or stable or not changing, and not thinking that it's just because your testosterone is going up that you have to sort of, that the PSA is going to go up too. The two don't always go together. So yeah, I think that's great information for the person who submitted that question. Here's another question. And how about breast pain or breast tissue growing? Can that be an effect of hormone therapy? Does that affect all men? No and no. So there are types of hormone therapy that have more effects in terms of the mammary glands, and those are more often the pill treatments. But sometimes that happens with standard injections, that we have patients that have that too, that they're going to have a growth in their breast tissue, but it's rare with that type of treatment. So that, I think, you want to talk to the doctor who prescribed the hormone therapy to not see if you could try something else, if that's a problem for you. And it's not something that we see very much. Okay. Here is a patient that here's a question we got. And it's a two-part question. So here's the first part. I had hormone therapy for 6 months, then I had radiation therapy, and I stopped 6 weeks ago. And I'm still having hot flashes. And the question is, how long are those side effects are going to last when you've had hormone therapy and it's stopped? So in this case, it was 6 months. The real answer is, I don't know. It really varies a lot from one patient to another. But in general, if the patient is younger, then their testosterone kind of rebounds more quickly. And the shorter amount of time that you have the hormone therapy, your testosterone kind of bounces back faster. But even in those factors, we've had really young patients who take some time really for their testosterone to bounce back up. There's always exceptions. But really, if you have injections, and let's say you have those for 3 months, then it takes about the same amount of time, 3 months usually, and it's not going to take 2 weeks. 1 to 2 months, I would say, after 3 months of hormone therapy, until you're really going to feel the effects of your testosterone rebounding. But sometimes we don't really know why some patients more than others take longer. But there are patients that it can take 6, 8, even 12 months. And we have people who stay at really low testosterone levels forever. And often there are some people where we stop the hormone therapy, but their blood levels are like they were still having hormone therapy. So it's hard to say, but the younger patients with shorter hormone therapy is when we see the testosterone levels coming back up quickly, but it varies a lot. Okay, thanks. And with COVID and all the vaccines that we're getting, and then the booster doses, here's a question we got. Can hormone therapy affect your immune system? Nope. because otherwise menopausal women would all be immunocompromised. So no, that would be sad. No, that's the answer. No, no worries there. Okay. And people who are getting radiation therapy, can it affect their immune system, radiation therapy? A little bit. It's not like it overall affects your immunity because immune system depends on a lot of factors. Sometimes, yes, there's a small decrease in your white blood cells and things like that. But if you're having a larger field of radiation, because it's going to affect your nerve tissue, but it's not at all like chemotherapy that really crashes your immune system. It's minimal or no effect. It's not something to really worry about. Okay, if you need your COVID booster, go get it. Yes, you have to, you should. You were just saying that a lot of times when you're having long-term hormone therapy, your testosterone level might never rebound to normal. Even after the treatment is over, it's like the treatment was continuing. So here's the question. If your testosterone levels never go back to normal, can you take testosterone replacement therapy, hormone replacement therapy? Lots of patients ask that. So it's hard. It's hard for a doctor to prescribe supplemental testosterone because it's like an absolute contraindication for someone who has prostate cancer. It's like putting lighter fluid on the fire, like prescribing testosterone would be sort of asking for recurrence of the cancer. I've never seen that. I've never seen anyone do that. In the future, when we have, evidence that the patient is absolutely 100% cured, maybe we'll do it. But right now, no, I think doctors are really, really reluctant to take that kind of risk. So here we're going to talk a little about sexuality. Do all men lose their sex drive when they're having hormone therapy? I would say probably yes. Sometimes, once in a while, sometimes I've had very few patients tell me that they still had a normal sex life and they could still have an erection, but it's a small minority, unfortunately, because really your sex drive is not just physical. I would say it's really a tiny minority that don't have any significant drop in their sex life. So would traditional erectile dysfunction treatments work when you're having hormone therapy? And really, when we prescribe the well-known medications like Viagra and that whole category of drugs, often they're not that effective because you have to have at least a minimal level of libido and sex drive. I mean, again, some people, it has helped a small minority who can go back to having a normal sex life. There are other things that we can do that are a little more, I'd say, invasive. So you can take injections of a medication right into the penis. And then you have to go to a special erectile dysfunction clinic. And that can help because it's a very local effect. It doesn't depend on the state of the rest of your system. So that's something to talk to your doctor about. But there are things that we can do. Can I take natural supplements to help with hot flashes and erectile dysfunctions? What do you think about supplements? I would say Yes, if you have, but if you find ones that work, I'd love to know about it. If there was a product like that that worked really well, then all of us would be really happy and we would prescribe that to all of our patients. So if you experience some that work, then yeah, talk to your doctor, because if it works for you, it could work for other patients. And sometimes if you're worried about it, I think the idea is to talk to your doctor about it. I mean, yes, it could work, but you want to just talk to your doctor about anything you're taking. Okay, we've got 2 questions left. One that we get a lot is when you're talking about standard hormone therapy that then stops working and your PSA goes up, and you're going to add new generation hormone therapy to that, and if the patient is a good candidate. So when you talked about new gen hormone therapy, you talked about PSA doubling times being short. Could you elaborate on that? What about this doubling idea? Because sometimes we have questions, we have patients, people say, if my PSA level went to 0.1 to 0.2, that means it doubled. And should I have a new gen hormone treatment? Can you talk a little more about doubling? Oh, it's a really, really good question. So the lower the number is, then doubling doesn't mean a lot. So if it's like 0.0001 and goes to 0.0002, then I don't think that's a big deal. But here, where we're talking about a very low level, then the doubling time is sort of less significant. It's more when you have higher numbers, when you're going to from 0.15 to 0.30 or 2.2 to 0.4, then that means a lot more than when you're at the very low limit of detection. So we're not just taking 2 blood tests. I often have patients who they get blood work from 2-3 months, and their level goes up, but then for a year it just stays totally stable. So we need to look at it over a longer period of time, take sometimes 2-3 rounds of blood work, and we look at the trend. And so that helps us estimate the doubling time. And sometimes even we need 3 or 4 blood work results, unless we have a really high number. And if it goes from 30 to 60, then we don't need to wait to see what it does if it's that high. Okay, great. One last question. Maybe you just want to comment on this because you touched on it before, and about how long can men survive with prostate cancer, do you think? A long time. When patients ask me for those kinds of numbers, I just shake my head and tell them, I don't know. It varies so much from one individual to another. And so numbers for one patient don't mean anything, but before we would have patients who developed resistant prostate cancer, we had a sort of average life expectancy of 18 months. And now we're not talking about that at all. We have so many options. And even the numbers that we're looking at now, they'll be longer in a year, in 2 years. We're looking at improving survival, quality of life, and why are there so many studies? Because sort of fortunately, unfortunately, it's such a common disease. And so we have so many patients that can give us a lot of data. and we can try different types of medications, and sometimes those are medications that really have an incredibly positive effect on them. So we're getting better all the time. So there you go. And so we also are working on quality of life for patients who have to undergo all these treatments. So thanks. I think we're getting to the end of this webinar. We're going to leave it there. Thank you so much, Dr. Lambert, for your really interesting presentation. And I think that we really got to most of the questions from our participants. And so maybe we can get back to people during the week if you had a question and we didn't answer it. It's the second time that we've done a webinar with you. And at the end of webinars, it always finishes on a positive note. So I hope that our participants feel that as well. I love how you really tell exactly what you think because you're living through this every day with your patients. And I think that you really connect very well with your patients. Okay, great. So our next webinar is going to be November 22nd at 7 p.m. And we're going to talk about testing and the importance of PSA in diagnosis and monitoring after prostate cancer. And that's going to be with Danielle Lowenstein, who is a surgeon at the Pierre Boucher Medical Center. So come join us for that. You can look at our Procure website and follow what we're doing there. And thank you for attending Procure en Parle. Thank you again, Dr. Lambert. Thank you to you.
Vous avez aimé les services de Procure? Alors n'hésitez pas à contribuer à procure.ca. Merci pour votre générosité.